In the trenches. Today, this is going to be very brief in the trenches, and I'm going to talk about two patients I saw today that are somewhat interesting. Number one is a 75-year-old patient who I saw last week. She had left lower extremity DVT, and I mentioned this one in the trenches, and I CT scanned her, and she had a large PE, right lower lobe, but normal LV function. She was dyspneic on exertion. Sent her out on Eliquis. She finished her first week at 10 twice a day, and she's now on 5 milligrams BID. Last week I echoed her, and the RV is okay. Minimally dilated, no McConnell sign. TAPSE is okay. She does not have the imaging requirements for a high risk intermediate PE, intermediate risk, high intermediate risk PE, but her troponin was elevated, not sky high, but it was 16. Anyway, I treated this person like an intermediate risk PE. On the low side, a low risk, intermediate risk PE, the low side, she would just be anticoagulated. She's still short of breath on exertion. Pulse ox was 98%. Resting, we walked around the office twice and it dropped to 94%. Still not hypoxic, her lungs are clear. I plan to follow her clinically. What will need to happen with this patient will be, if she's still short of breath in 3 months, she'll need an echo. And if she has any right ventricular dysfunction or any abnormalities like that, she'll need a VQ scan to rule out chronic thromboembolic pulmonary hypertension. And the test for that is a VQ scan, and hopefully that will not happen. That's that patient. Another patient, completely different topic, is a 65-year-old. 65-year-old man, and I see in the report he has joint aches. He thinks he has Lyme disease, but he has no exposure. And basically, this patient was complaining of shoulder pain and hip pain. Came on, he's been having it a little under a week. Shoulder, hip, maybe a little in the neck. No fevers, night sweats, no headaches, no jaw claudication, no visual loss. I didn't think about Lyme disease. I thought he had maybe polymyalgia rheumatica. That's not an uncommon disease. So I ordered a stat, sed rate, and CRP. His CRP was around 25.5, with top normal, I think, under 6 or whatever. But this was raised. The sed rate was only 25. So the issue is, what do you do here? You know, there were no real other tests to draw. And he sounded like polymyalgia rheumatica, and some of these patients have normal sed rates. Unlike giant cell arteritis, it's close cousin. And this is also the beginning of this. So what I plan to do is started him on 20 milligrams of prednisone a day. And I'll see him back in a week. And if he's better, that's a litmus test. I think this is the diagnosis. And I'll keep him on this and start to taper. If he's like 70% better, I may up the prednisone dose a little bit. If he's no better, this is not the diagnosis. We'll have to explore other options. But you can see polymyalgia rheumatica with normal sed rate. That doesn't rule it out. And with this history, I still think this is the most likely diagnosis. Stay tuned.